Thanks for having me here today. I also appreciate everyone's trust in the cardiology group at Roper. I think we got a great team, and thank you for trusting us with taking care of your patients. Dr. Lyons did a great job of talking about treatment of hypertension, and I'm going to talk about something that's new. Just a correction on the agenda there. It's renal artery denervation, not renal vein denervation. Not that it makes a whole lot of difference as far as what you're going to learn today. But something that we've been doing, we did our first case in June of this year. It's been available, approved in the United States in kind of late 2024. And we've had great success with the cases we've done so far. And I just want to kind of talk about what it's all about, why we do it, and where we're going from here. So renal denervation is a complementary option to lifestyle changes and pharmacological therapy like you've learned about already. Obviously, we talk about lifestyle changes, medications, and renal denervation is now recommended by SCAI, which is one of our organizations, specifically the Society of Cardiovascular Interventions, basically, and their position statement, which I'll have a little QR code for at the end if you want to look at that, but it is deemed to be appropriate therapy for patients who have not been fully treated with all of these other options that we have out there. I'm just going to do a really brief review of what Dr. Lyons just talked about and look at it in a slightly different way. A patient coming to me, we do take care of primary hypertension once in a while in cardiology, but not so often. But I had a patient come in and says, why do I have hypertension? And I really need to start showing people this chart. This is from the European Society of Cardiology, and there isn't one answer. There's dozens and dozens of answers why people have hypertension, and most people have multiple reasons why they have hypertension. We're going to focus today, though, on the autonomic nervous system because all of these other issues we've talked about already. But what can we do with the autonomic nervous system? I like the European Society, their guidelines. I will tell you, I'm not going to get political about things, but the Europeans actually do some things better than we Americans. We're a little bit stuck up about ourselves, but the European societies tend to have, they're a little ahead of us on some things, and I'm sure our guidelines are going to be melding more towards theirs. And they're not that different. Although there are some interesting differences, they actually recommend starting patients on low-dose double medical therapy under most circumstances. They do give some caveats. Frail people, etc., elderly, probably start with single therapy. But they actually suggest starting with low-dose double therapy, and actually they recommend usually starting on combo pills. They do that for, I think, very solid reasons. Compliance is much better in one pill, especially one pill once a day rather than multiple pills multiple times a day. Rechecking every few months, going to low-dose triple therapy, and you notice that they don't actually recommend maxing out doses of pills before going on to another drug. They actually increase the number of drugs before going to super high doses. Working on down maximally tolerated triple combination therapy, and then this is when we get to something like a cardiologist. We don't have a hypertension clinic per se in the Charleston area. There's a little bit of it over at MUSC, but certainly this is when you start thinking about working up for secondary causes and getting over to see somebody like myself that deals with more difficult cases of hypertension. Testing for adherence is also always very important. Notice that they've actually put beta blockers off to the side. There are a lot of reasons why in cardiology we have a lot of patients on beta blockers. I just got some data. I don't know how it came through Epic. I got a message about this in my Roper email the other day. My number one drug, metoprolol succinate, but that's not for hypertension. It's for ischemic heart disease and congestive heart failure. So, but that is my number one prescribed drug, and then standard hypertensive drugs after that. I think spironolactone is massively underused, and it should be really considered in the appropriate patient as no more than fourth in your order of drugs to add. But like I said, I love the ESC's formulation of things. It's a little bit simpler to follow and really makes a lot of sense to me. We just talked about what's the definition of resistant hypertension. So it's blood pressure remaining above goal despite 3 or more medications of different classes, maximally tolerated doses, and I should say different classes that have data to support their use. There are a lot of drugs out there that don't actually have outcomes data. The classes that we talked about just now, ACEs and ARBs, calcium channel blockers, thiazide diuretics, those are the ones that really have excellent outcomes data. Attempted adherence to lifestyle modification, I kind of put the emphasis on attempted. You can't, and it's not expected that patients are absolutely adherent to everything that we do, but these are the recommendations that we talked about: weight loss, sodium restriction, potassium intake increase is also important. It's not talked about a lot, but it does help a lot. Increased exercise, reduction in alcohol intake, and sleep apnea therapy. Extremely important. I send a lot of patients for sleep studies for hypertension workup. And again, adherence to sleep apnea treatment is not the greatest, but at least getting them there and getting them started in that is very helpful. So patients with resistant hypertension should be considered for workup of secondary causes and a referral to a specialist. We talked about this a little bit already. Primary hyperaldo, the aldo-renin ratio is very, very easy to do. We do a fair amount of screening for renovascular hypertension. Back when I started in interventional cardiology 30 years ago, I don't like to talk about the length of time, but we were doing a lot of renal artery stenting back then. The trials that looked into that actually didn't have very good outcomes to them. There are probably a fair number of reasons for that. Probably a lot of them had to do with patient selection and the quality of the procedures we were doing. We weren't probably getting great results. But renal artery stenting went away, basically extremely rare over the last 15 to 20 years. But we've actually found that there's more and more utilization of that now, particularly now that we're doing renal artery denervation. But easy scanning with renal artery duplex scanning, CTAs can be very beneficial, and MRAs also can be beneficial. A lot of false positives, a fair number of false negatives. Which I have found quite a bit now, because now that I'm doing renal artery denervation, I'm having to do angiograms on all those patients, and it's pretty remarkable how many renal artery stenosis cases we've missed. I've done 3 renal stents out of the slightly more than a dozen cases I've done, so it's not unheard of for these screening tests to miss stuff. Pheochromocytoma, I've finished my medicine residency in 1993, and I've yet to diagnose a case of pheochromocytoma, and it makes me very bitter. Everybody talks about it like it's really cool. You want to diagnose it, and you're going to fix these people. I don't know. I'm just striking out. At any rate, plasma-free metanephrines is the screening test I do. I think it's fairly well documented. That's a reasonably good screening test, certainly not a very high specificity. Easy to do instead of the 24-hour urine collections, et cetera, and it is available in the Roper system. Sleep studies, obviously. Cushing's disease, we don't really get into that a lot, whether random cortisol is good enough, 24-hour urine cortisol, or dexamethasone suppression test. Almost nobody comes to me without a TSH check. Hyperparathyroidism certainly can cause hypertension. We don't really see a lot of that either. So, what is renal artery denervation, and why have we thought that this might be a good idea? A lot of crosstalk between the kidneys and the brain. My nephrology colleagues will of course tell me that the kidneys run the brain, and cardiologists will tell the kidney doctors that the heart runs the kidneys. So there's obviously a lot of internecine warfare going on here, but a lot of afferent signals go into the brain from the kidneys. So there are baroreceptors throughout the renal arteries, and they're constantly telling the brain to lower or raise the blood pressure. Obviously, the reasoning for doing renal artery stenting is to potentially increase the renal arterial pressure and then decrease the afferent signals to the brain to reduce CNS output of sympathetic drive. Long-term effects of elevated sympathetic drive, vasoconstriction, reduced compliant vessels, atherosclerosis, smooth muscle migration, so more stiffening of the vessels, increased contractility and rate upregulation into the heart, leading to left ventricular hypertrophy, myocardial ischemia, arrhythmia, heart failure, insulin resistance, impaired glucose metabolism, and then efferent signals back to the kidneys, doing all sorts of malicious things like reducing renal blood flow, increasing proteinuria, decreasing BNP resistance. Sodium reabsorption is increased, water retention with causing hypervolemia and increased wall stiffness, renin aldosterone activation, so you have increase and then sort of a vicious cycle of increased sympathetic activity, renal sodium and water retention, et cetera. So this is why the concept of renal artery denervation started getting studied about 20 years ago. And it's taken all this time to basically get the trials done. Again, a lot of patient selection issues. The techniques that were first being used were not sufficient to actually ablate the renal nerves very well. And it took one company in particular, Medtronic, spent almost 20 years developing their system with lots and lots of negative trials, but they kept at it. And they were really the first to come out with good data. Another company called Recor Medical has a device that's available nationwide. These are the two systems that are available in the United States. There's more available in Europe. And we probably in the next couple of years will have at least 2 or 3 more of the catheter companies coming out with their version of renal denervation. There are slightly different techniques. Medtronic, and I'm going to go through these a little bit. One is radiofrequency denervation, so similar to any kind of ablative technique that uses radiofrequency, including catheter-based denervation for atrial arrhythmias and ventricular arrhythmias. Recor Medical uses ultrasound renal denervation. Their system is called the Paradise system. So basically, it's like a balloon catheter that goes into the renal arteries. There's a little ultrasound transducer there, and much like lithotripsy, it's just sending out very high-frequency ultrasound waves with the idea of penetrating through the wall of the renal artery and destroying or modifying the functionality of the renal nerves that are basically adherent to the adventitia of the renal arteries. Fairly easy to use. We have not chosen to go with that company. We really had to choose one to go with so that we're technically adept at using one well, so we decided to go with the other company. I'm going to show you the data from this company. There's nothing negative about it. We had to choose one, so we went with the other. But this is a very useful, very, very good technique. And then there's the Simplicity spiral system from Medtronic. Uses a catheter which becomes spiral shaped or corkscrew shaped when we put it into the kidney artery. It gets attached to this generator and it ablates the nerves. This is a little mock-up of exactly how it works. So the first thing I do is I put a catheter out here in the aorta, a guiding catheter. It's exactly like doing an angioplasty in our heart. We put a guide wire down the different branches, and in this system, we use any branch that's greater than 3 millimeters in diameter. We're going to get a wire in there, and we're going to ablate. So the catheter goes down over top of the wire. We then retract the wire, and the catheter itself has sort of a helix built into it, so when the wire is pulled back, the helix forms itself. And then those little emitters then emit radio frequency. You can see how it kind of assumes this corkscrew shape inside the artery and sequentially ablates multiple different spots along the route and kills off those nerves. We can watch what we're doing the whole time. We watch for heat rise. We watch for impedance, which is like, resistance. And the system can actually automatically stop if something's not working right. Quite easy. This procedure takes us about an hour and a half because patients often have multiple branches, sometimes multiple accessory branches into their renal, so they might have multiple renal arteries themselves. But I can do the cases in about an hour and a half or so. And I wanted to show you the data from the two different companies, just so that you have an idea of where we are. Obviously, it's always important to realize that these are studies done on different groups of patients, so you don't want to try to compare one device versus another. But I would say that in essence, they both have basically the same outcomes data. Both techniques used their sort of first trials. They did them off medication, so you had patients that were on medication. They had to go through a 1 or 2 month long washout period, so literally no antihypertensive medications. So you could not have patients who were wildly out of control to begin with. They had to meet parameters, so they couldn't have blood pressures over 190 all the time while they were in this washout period. And then they went through and they did their again, this is the ultrasound technique. And what do you see at the end of the 2 month period of treatment? They had a substantial drop in blood pressure, and from baseline to 2 months, the sham patients got a little bit of a drop in blood pressure. The denervation, the active treatment patients got a more substantial drop. So about a 6.3 millimeter drop in blood pressure over 2 months. Doesn't sound particularly exciting, but remembering again about with Dr. Lyons' data that she shows, that 10-point drop in blood pressure does lead to a very substantial drop in outcomes long term. This is the TRIO study, which is an interesting way of doing it. They had patients who were all had resistant hypertension. They actually were taken off of their normal medications and given a pill with 3 drugs in it. And then the patients were either randomized to active treatment or a sham procedure. So all the patients underwent the same procedure as far as they realized. They had a catheter put in their groin. The patients that were sham treated just had a renal angiogram done, and the patients that got active treatment got the ultrasound treatment done. And they had a substantial drop in blood pressure with a mean between group difference of about 4.5 millimeter drop. This is at 2 months. A lot of people are going to want to know, what's the long-term efficacy of something like this? Does it just come back? Do the nerves grow back? Well, it's actually interesting. You'll see this same sort of data with the other device. We have a further drop over time, and this is actually statistically significant. So I think what you could say is from this is from the SOLO trial. This is the off-med trial. By the time they get out 6 months to 36 months, it is not unreasonable to expect somewhere in that 15 to 20%, 20 millimeter drop in blood pressure. Remembering again that the sham patients did have some drop as well, but this is an absolute drop from baseline for the treated patients. And you also look at the number of medications that patients were on. Notice that nobody is on 0 medications, but they're no longer on 3 drugs. They might be on 1 drug or a little bit more than 1 drug at that time. Something that we do not tell patients is that I'm going to do this procedure and you are not going to take blood pressure medicine any longer. That's not an expectation whatsoever. This is the Simplicity group of studies. So this is with the spiral Medtronic device that we use. Their first studies were with an off medicine protocol, very similar. And at 3 months, 9 millimeter drop. And then you look at on medications, the on-med full cohort, they had about a 10 millimeter drop at 6 months. And the pilot study, which was a much smaller group of patients, you have a 20 millimeter drop at 3 years. So again, you see this trending of this improved blood pressure control over time, which was maybe expected, maybe not expected, that they would have this sort of trailing effect that gets better. This is the global registry, so this is a long-term, non-randomized trial group, but it's a much larger cohort you can see there. And again, at 6 months and at 3 years, a substantial drop in blood pressure, continuing to improve over time. One of the nice things about renal denervation is it's not like a pill. It is working 24 hours a day, and they can't not take the pill. So they get excellent blood pressure drop. So this is, baseline, and this is at 3 months. And you can see throughout the 24-hour cycle, it is improved, whereas the shams had no improvement over time. Safety. Obviously, we're doing an invasive procedure on somebody. Safety is outstanding. It's far better than cardiac intervention. 0.4% in the trials, 0.4% rate of major adverse events. That's either severe bleeding complication. We are doing an invasive catheterization-based procedure. 0.4% major complications is phenomenal, far better than we can say in the rest of interventional cardiology. Does kidney function go down? Nope. There's no drop in GFR over 3 years, maybe a slight trending downwards, over time. It's not statistically significant. It would not be surprising, obviously, with 3-year follow-up on a large cohort of patients with hypertension, but there's no direct detrimental effect of the procedure. So very effective, very safe, both acutely and long-term. So Society of Cardiac Angiography and Intervention says this is a good therapy for patients with uncontrolled hypertension despite attempting lifestyle modification and hypertensive meds who are either intolerant of additional medication or don't want to be on additional medication. Patients at high risk seem to have the greatest benefit from the procedure. This is really coming on and becoming a good technique. So who's a good candidate? The CMS finally came out with their national coverage determination, so Roper is now getting paid for me to do these procedures, which is always nice. It's easier to talk them into letting me do it if they get paid for it. So who is an appropriate candidate according to CMS? Diagnosis of uncontrolled hypertension despite active management. You have not either, you have examined them for secondary causes and you are treating them appropriately. Uncontrolled is defined by ambulatory blood pressure monitoring or serial home blood pressure readings. Again, we don't do ambulatory blood pressure monitoring in the Roper system. I do have patients bring in their blood pressure logs. I didn't know about the automatic linking. That's nice. I'll start using that. But I have them bring in the logs. I actually take a photograph of them, put them in the chart. When we go out for prior authorization, that's part of my data that I send to the insurance companies. We have not actually been turned down, so we've gotten good approval. I am obviously fairly selective about who I'm doing these on. And again, CMS confirms they should be uncontrolled despite lifestyle modification and maximally tolerated antihypertensive therapy on stable meds for greater than 6 weeks. They did not put this in there, but I will say that the studies were all done in patients with GFRs greater than 45. I have done several patients whose GFRs were 40. So it's not that it's not safe, it's just that it's not studied, and we've not had an issue with that either. So find it, cardiologists always find a way to do an invasive way of fixing something that internists can use pills for, but I just want to say this is for in addition to pills. And I guess we'll keep going and we'll take questions later.
We have a question.
Yeah.
Just on the renal stuff, a lot of our tough to control hypertensives also have advanced renal disease, and you mentioned the GFR at the end. Is there a number that we shouldn't even think about referring you to?
If they're in the 30s, we probably shouldn't be, because there's hopefully data coming a lot around that, but we just don't know. So great, thanks.